So today we're doing the RN Exam 3 review. So next week you'll be coming to class, you'll have an RN, your exam 3, and most of the professors are doing some type of HESI review to follow. Now, all of you that are here, let me let you know that on Sunday of week 11 at 2 o'clock, I'm going to be doing what I call an open foreign question answers. And right now, I've taken it from a Word document and I'm placing it on a PowerPoint. So we can go over it that way. I think it's more interactive and it keeps you more interested than just reading a piece of paper. So I'm almost done with that already. So everybody is welcome. What date is that? Well, I don't have my phone. Of course, my grandson's playing on it. It's not this Sunday, which is week 10. It's the following Sunday. So if today's the 8th, 9th, 10th, 11th, 18th.
So the 18th, yeah.
Week 11, yes. And it's great. I've had students who have come back to me and said, the way I taught it was spot on. I'm gonna make you think. So it's available. And of course, the recordings are available for all students. And actually that one, I post it in all of your classes to get it out that quick because it's Sunday of HESI week. So let's go ahead and let's do our review. So there are 77 slides. Some of them are just pictures. So it's not that crazy, not that long of a review. So it won't be overwhelming. So let's start with the endocrine system. You think endocrine, the first thing you think of is diabetes, right? So there's type 1 and type 2 diabetes. Children, especially the younger ones, are type 1. And remember, once type 1 as a younger child, always a type 1. It never converts. I've had students with that misnomer to let you know. Symptoms, what do you see? You're going to see 3 Ps. Now there's another condition, diabetes insipidus is only 2 Ps. So remember that. It's a question that's always missed. So polyphagia, I'm hungry. Polyuria, I'm urinating. And polydipsia, you're thirsty, you're hungry, and you're peeing a lot. That's what it looks like. Now, what if you get a child, an adolescent comes in who is overweight, BMI is really high, and you see them urinating a lot? Well, we could immediately think that it might be diabetes, but always remember to rule out other things like urinary tract infections. So we'll be doing a urinalysis. Yes, we'll be doing the hemoglobin A1C, but remember to rule out it all.
OSHA 1.
These are all of your signs and symptoms. Again, I told you, lots of nice pictures. Look at it and what you see. Now, there's something that we have in diabetes. We have times where blood sugars just go up, and it's no protein, no ketones are seen, right? That's just an elevated blood sugar. That is hyperglycemia. Now, when you see high blood sugar and the presence of protein in the urine, that is diabetic ketoacidosis. And that is a difference between hyperglycemia and DKA, okay? So what do you see? Well, this child is going to be drowsy. They can hardly hold their head up. They're pale. They've got this breath, as I said, smells like a rotten peach. And literally, it's like, oh, I smell the sugar. It's that much. And then it could go into hypotension and bradycardia. Then another picture to show you all about it. How do we treat DKA? Number 1, bolus normal saline. Let's dilute the sugar, okay? Now, diabetes and hypoglycemia. You have low blood sugar. What would a kid or an adult look like? Well, you're going to see them nauseous, vomiting, but that jittery, that restless, sweaty, dizzy, those are absolutely what you would see. So if a child is awake and alert, we can give them something orally. We could give orange juice, we could give milk, we could give a little piece of sugar or like a lifesaver, and then they need to go get something to eat to cover it. So again, hypoglycemia, signs and symptoms, again, these are the things that you will see. All right, let's go into the pituitary gland. Remember, there's two lobes, anterior and posterior. So the anterior has everything to do with growth. The posterior has to do with urine, okay? Too much, too little. And they have different hormones. So if you have a child who's getting too much or too little growth hormone, there's things that we need to do. So hyperpituitarism, these children get tall. Is also called gigantism. They could get up to 8 feet tall, and usually it's due to a tumor, and then we'll remove it. But whether it's been removed or there's hypopituitarism, they need that growth hormone, and it should be given usually daily, and it is a subcutaneous injection. It's just like a child who's diabetic who needs to get insulin injections every day. Same thing. Remember, the child needs to learn it and to be compliant with it. So how do we find these things? How would we know? Well, I've said it all through my class. You're going to see every time we see a child, we're going to measure the weight and we're going to measure their height because we're looking at growth, right? That's one of the signs and symptoms of it. Now, you get a child who looks short. According to the charts, they're in the 5 percentile. Don't assume that it's a growth problem. Ask about the family. Is the family all short? And conversely, if they're too tall, according to growth charts, then ask your family, are they all tall people? That makes a difference in the care for these children because it could be normal for them. Precocious puberty is when the sex characteristics start early. Usually you'll start seeing them with young girls getting menses and breasts at age 6, which you don't want, or boys with facial hair, not normal. Now, the posterior lobe has a lot to do with urine output. So we have growth and we have that urine management. So diabetes insipidus has nothing to do with blood sugars. It has only everything to do about urine output. Remember, this is only 2 P's. It is polyuria, polydipsia, which means you're urinating and drinking and urinating and drinking. Be careful with this because all of that urine output, you could lose all your potassium. So you really have to watch your electrolytes with that. Now, syndrome of inappropriate antidiuretic hormone or against diuresis, antidiuretic, against urinating, which means you're holding on to everything. That means this child has fluid everywhere, and you're going to see swelling, edema, eyes, tongue. You'll see them puffing up with all of these fluids. So how do we treat somebody who is holding on to their urine? Well, fluid restriction, salt restriction. At both of these, anything to do with fluid, you're going to do intake, output, and daily weights. And that's going to monitor that fluid coming in and out. Now, the coolest thing is little infants, they do get diabetes insipidus, and they're always hungry. They're crying. You give them a bottle of water, and their crying stops, and they're satisfied. So that's actually one of the first things we look at for these children. And we know that with diabetes insipidus, you could tell them to stop drinking, but it's going to make no difference on how much urine output. So how do we treat diabetes insipidus? Of course, number one, we're going to be monitoring intake, output, daily weights. And we're going to teach them to do that at home. And usually they're going to get a vasopressin. Now it could be administered intranasally or IM. And this is not something that there's a cure. You just have to be monitoring. So daily weights at home are very important. And if they're gaining weight, they need to call the doctor, or they need to know what is the cutoff on when to give themselves this medicine. Here's another picture. SIADH is just soaked up. Water everywhere, right? So how do we treat it? Well, it's fluid balance again. Intake, output, daily weights, right? And then we're going to be looking for those signs of fluid overload. It could be congestive heart failure, right? Could be dependent edema, swelling everywhere. So how do we treat it? Well, if they're holding on to fluids, we're going to do a fluid restriction, low sodium diet. And one of the side effects, because of the increase in sodium and chloride, is seizures. So we'll have to be monitoring for that. And what we do is give that antagonist vasopressin, which stops the secretion of the hormone and allows the child to urinate normally. These children and family of both DI and SIADH need really good education and teaching. Again, there's another picture to show it to you, to show it to if you need it more of a visual. Now, thyroid. It could be too much or too little. Now, too much is called Graves' disease, and it's just the hormone produces too much. And the one concern about too much, these children can go into a thyroid storm with too much, whether it's just thyroid does it, or maybe the child took 2 doses that day for a couple of days, and all of a sudden the thyroid just, starts, producing. Well, thyroid, I mean, when you don't take your pill for several days. So that thyroid starts producing, and what happens is what we call a thyroid storm. They get hyperthermic, they get tachycardic, they get confused. I actually saw an X-ray tech where I worked go into a thyroid storm right at work, and I worked in the ER, so she was lucky. We brought her in and we gave her a beta blocker. And that helped. And then she ended up getting an ablation, getting rid of the thyroid. Now, we can do the surgical treatment, but usually we'll just take medicine. And there's something called polypropyl, it's all they call PTU is on the label. It causes leukopenia. Well, what's leukopenia? Not enough white cells. So you're going to see a lot of infections, sore throat, fevers. And if they get leukopenia, they're going to treat it with corticosteroids. And that's going to help that fever not be there, because it's because of the medicine, not because of a fever, okay? And at that case, these children, if it continues, these children will get the surgical ablation of that thyroid. Now, thyroid, that's not enough being produced. We know we need it for cognition. It's without it, they'll have mental decline, retardation. So we don't want to hold or misdiagnose these children with hypothyroidism. Usually these are the children at birth that don't have a stool in the first day or two. And that's something to look for, is thyroid, a hypothyroid. So what do you see? Well, I've already told you it has to do with their mental. So they're going to be fine motors, gross motors. They're going to be at the developmental level they should be. If they don't get the thyroid hormone, they're not going to grow like they should. You're going to see dry skin, they have puffy eyes, and the hair is sparse. Do you see that? It doesn't grow the way it should. And constipation, and they're going to be tired, and they're going to be sleepy. Very much all the symptoms you see in adults, except for the growth, because adults have already stopped growing, right? So again, another picture to show it to you. So hypothyroidism, everything slow, slow, slow. So that's the weight gain, the low heart rate. Hyperthyroidism is the rapid heart rate and weight loss because the body's burning it up so quick. I've heard many women say, yeah, I've gained weight because my thyroid's not working well, because you gain weight with it. It's not always that case. So adrenal cortical insufficiency. Now, this is your adrenal gland, and your adrenal gland produces cortisol and aldosterone. Many times, for many conditions, we need to give a steroid, usually prednisone. Like, for instance, rheumatoid arthritis. One of the things that we do to stop the inflammation and the pain is given. But sometimes either you're taking the medicine or the adrenal gland starts to produce too much cortisol. What happens? Well, too much is due to what you see is something called Cushing syndrome. Cushing syndrome, what do you see? Well, ruddy cheeks. Have you ever heard of that? Well, ruddy means big red cheeks, but they call it ruddy. I know it's a really weird word, but it's ruddy cheeks. You're also going to see these thin extremities. You're going to see fat deposits all on the abdomen. You're going to see big moon face on these children. You might even see acne on these kids. So this is the signs of too much adrenal hormone cortisol. And this is also a picture of it. You'll get hair growth. Usually kids on the chin will get it, which is not normal. That moon face, they'll gain weight. They'll have those fatty areas on the face, the trunk, big belly will go on. And then with anything with steroids, poor wound healing makes sense, and bruising. Now, another thing with not enough adrenal hormone, it has to do with the assignment of sex on an infant. So not enough, these children are born with ambiguous external genitalia, which means you can have a penis and a vagina, or testicles and a vagina. It's all different combinations. I've seen one in my lifetime, and I was like, okay, so what do we do? Well, at birth, we don't know if it's a boy or girl. Can you imagine the parents? So what did you have? I don't know. And they have to go and look and make a good decision. What are we going to assign to this child? What sex? These children, they have electrolyte imbalances, hyponatremia, hyperkalemia. And what do? Well, they assign, they might do surgeries for correction, but these children will be getting cortisol, which is hydrocortisone or prednisone. And we know that in cases of stress or growing, those doses must be increased. Neurological dysfunction. So neuro, we know that we can do many things to evaluate it. So we do lumbar punctures in case there's something with meningitis or headaches or pressure. We're head injuries, we're going to be monitoring all those functions. As I said, meningitis, edema of the head. It's a lot of pressure in there. We'll be treating that, hydrocephalus and seizures, and we're going to go into those. So seizures in children are what happens. There's a piece of brain that just says, you know, I just want to spark. And it sparks and it causes a reaction of different things. It could go from a twitching eye all the way to tonic-clonic, where you become unconscious with all your extremities moving and foaming at the mouth. So what do we do for these children? Well, parents are always going to ask you, so does my child have epilepsy? Well, we know that they have to have 2 or more unprovoked seizures, about 24 hours apart, okay? And that's sort of, okay, we need to look at it closer. One seizure does not make them a epileptic, and it doesn't require medications. We know in children, a lot of times it's due to a fever, right? So what all can cause a fever? Well, infections, lesions, hemorrhages, some metabolic disorders, trauma, falling, right? brain malformations, and children are born with the brain not completely put the way it should. Genetic, toxic, and of course, as I said, fever. So some of these children having a seizure, what do you need to do? Well, it's all about safety. There's nothing that you can do while they're having a seizure except protect them and to monitor and keep track of the time and what it looked like. So what do? Well, you put the bed flat, you take the pillow off, roll them on their side because you don't want them to vomit and aspirate. If you can raise the side rails, if you have something to pat them with, do that. And make sure the bed doesn't have any toys that are sharp, that can harm them. So clear the bed from all that stuff. So our priority is the safety, right? And this is something we need to teach the parents, because if a child had a febrile seizure, chances are they're going to have it again. So these are all the types, and you're all going to say, so I need to know all of them? Well, no, you just need to know that there is very easy, simple type of seizures. They used to call them petite malls, which could be twitching eye or quivering lip, or maybe one arm moves, to the point of, and this is the other one, grand mal. This is the tonic-clonic, where they go flexion, extension, they're moving, they lose consciousness, they're jerking, foaming at the mouth. And that is the classic tonic-clonic type of seizure. Cerebral palsy, just covered this week in class. The one that we always think about with cerebral palsy is spastic, which it basically is what the definition. It's this posture, this movement. It's not that you can't control yourself. I call it like a on and off switch, where they move and stop, and they're jittery, and their muscles tighten up really tight. And that's what makes it the spastic. We usually test on the spastic one. The other ones are, again, they're types, but they're all different levels of it. But spastic is the one that we usually look at. Head injuries. I mean, kids are always falling, right? You remember me talking about toddlers, the dive bomb kids. They jump off the couch, they miss going to the other couch, hit the floor, hit their head, right? It's what they do. And then it gets to the point where they get up and fall out of the second floor balcony. And I've seen that more than once. So what is a head injury? It is the scalp, the skull, the meninges, or the brain are affected due to this trauma. It's usually due to falls, always motor vehicles going to be in there. And of course, they're always on bicycles or playing sports that can cause them. So how do we take care of this child with a head injury? Well, we're going to, of course, do the x-rays and CTs and all that and see where the fractures or hematomas or stuff are. But we need to evaluate their neurological status. So we are going to monitor their level of consciousness. If it changes, or if you're unable to wake them, that is a sign of increasing pressure in the brain. Also, if they get a headache that worsens or awakes them from sleep, that's another sign pressure's increasing. Vomiting, that becomes more and more and more. And then, of course, those pupils, they're not reacting the way they should. They say a fixed dilated pupil is a neurologic emergency, and it's probably pressures building up in that brain, and they need to go in there and evacuate what's going on. So here again, these are the things I just said. Nursing care for head injury, change of level of consciousness, or they're acting strange or asking questions for the 10th time. Restlessness, difficulty aroused, vomiting more than 3 times, pupillary changes, vision changes. Maybe they can't walk, they're falling over, that can happen. And the headache that becomes more, wakes them up. And as I said, a fixed dilated pupil is a neurologic emergency. Spinal cord injuries, these are the children that come in, usually off of rescue from a helicopter, and they are with neck brace, taped to headboards, and we're worried about their spine. The biggest thing beyond anything is to keep it immobilized. I've told my class the story about a 16-year-old. He was slid into third base and had an angulated C5, C6 fracture and already had numbness in his lower legs. And I was the trauma nurse, primary, and my job was to keep that neck straight. And we even did an MRI through the ER. Well, the end of the story, this kid a year later walked into the ER and gave me a hug and told me thank you. He had absolutely no residual paralysis. So yes, we can help children or we can really hurt them. Now, what is meningitis? Meningitis is an inflammation of the meninges and it hurts. You see those fevers, those chills, this obstistonitis, which is that severe neck stiffness. And you'll see them really holding their heads and they hurt. So how do we treat this? Well, meningitis is either viral or it is bacterial. And we need to find out what is causing it as soon as we can. And how do we do that? Well, we do a spinal tap and look at the cerebral spinal fluid. That cerebral spinal fluid on a child that has bacterial meningitis is going to look milky, look white. Viral is going to be clear. And we know priority is to get the antibiotic in as soon as possible. We need to get that bacteria under control so it doesn't cause permanent damage. Make sure that we look at those children after the spinal tap and try to keep them laying down. It's just like giving spinal anesthesia. They can get headaches afterwards, and they already have one, right? Now, how do we care for it? As I said, number one is those antibiotics. And because they hurt, every noise, light, all these stuff bother them, minimal stimulation. Now, a lot of times because of the inflammation, they get cerebral edema, extra fluid on their head. So how do we take care and get rid of fluid of this child? Well, if we look at congestive heart failure, you're going to say furosemide, right? Well, it does not work with heads. Mannitol is what we give. It's that white, thick liquid. We look for crystals in it, right? And it works on the head. And how do we know the mannitol is working? Well, we see them urinating, right? It's a diuretic. So if we see them start to urinate after it, we know that they're getting rid of that extra fluid. And what do we need to monitor? Well, we're talking about urine again, intake, output, and daily weights if it's possible. Children with a positive tap of bacteria must be isolated for 24 hours. And we're going to do minimal care, and we do it all at the same time. We're not going to keep bothering these children. We need to do that cluster care for them. So we're going to be monitoring these children just like a head injury. Level of consciousness, looking for their if they're alert or if they're becoming more lethargic, headaches, projectile vomiting. If it gets to that point, we know there's a problem. And infants, it's so easy to tell if there's extra fluid on an infant's head. At rest, sitting, a bulging fontanelle, that's a problem. And then, of course, if they're hard to wake up to feed would be, but that fontanelle is key. Myelomeningocele. This is when you have the meninges and the spinal cord are of the lower lumbar area are pulled up and out onto the skin. It didn't close up like it should. Well, think about they had to pull and stretch to get that into that big purple blob on the back. they have really ripped nerves there. So there's going to be motor and sensation is not going to be there the way it should. So it's the lower part of the body that may be slightly or completely paralyzed. And our priority is to make sure they're urinating. Okay. Now, they need to make sure they're urinating because they don't feel it. And they also need to make sure that they're moving their bowels. They don't feel these things. When this kid comes to the unit and you're notified it's a myelomeningocele, there's some things you need to have at the bedside. And the one really important thing is normal saline. And why? Well, the tissue is going to dry out. And we need to keep the tissue integrity nice and moist, but it needs to be sterile. And then we're going to keep a moist, sterile dressing on it. We do not want that spinal cord to get an infection. So you hear, we're getting one of these children, make sure that you get the sterile normal saline and sterile dressings to put on it. Now, hydrocephalus is when the brain is too much fluid. And these children will have this there for life. Now, remember, they grow. So there's a long tube, catheter that goes from the fourth ventricle behind the ear, down the front of the neck, down the front of the body, into the abdomen. And it drains fluid. So we'll be monitoring head circumference and abdominal circumference just to see if it's too much fluid going on. Now, on an older kid that's able to tell you how they feel, how would you know that that catheter is not working? Well, fluid's going to build up in that head, right? They're going to complain of headaches and they're going to start vomiting. So these children, if we see that, we need to go and look at that shunt and make sure that they go to surgery and they usually replace it, revise it. They do whatever they need to do, okay? So that's what we do with a VP shunt. Always, any comatose child, respiratory is our number one. And sometimes when we have a kid who's unconscious or really not responding, how do we know that these children are having pain or there's something going on? Well, blood pressure and heart rate go up, even on children paralyzed and sedated. And you'll see them go, say they're running a pulse of 100, all of a sudden it's 130. Something's going on. It's either a temperature, it could be too much urine output, or it could be pain. Duchenne muscular dystrophy is the most common of all the muscular dystrophies that we have, and it's due to mom X-linked recessive trait. It's usually found on males ages 3 to 7, and what we see is that they were walking, and then all of a sudden their muscles are getting weaker. They start waddling, placing their feet carefully, and they're falling. They also, when they get up off the floor, they're like me. They climb up their legs with their hands to help them up, which is called Gower sign. Their low back is curved inwards, and you'll see hypertrophic muscles in the upper arms and the thighs. And these children will have some sort of mental impairment. Because of the muscle wasting and the decrease in movement, they usually do have more weight. They tend to be more obese. How do we diagnose these children? So you get this little 4-year-old boy who's starting to fall, and you see this curve, and look at the muscles. Well, we're going to be doing what we call an EMG. And what it does, electrical shock goes into the muscle, and we look at the contractions. Remember, it's like going to the gym and working out. So make sure that we tell the parents, it's going to hurt, and we'll be giving them some ibuprofen or Tylenol when they come back to the floor. So these are all the things I just said. The EMG's done. Those are the signs you see. And again, they do have some mental impairments. Drowning, submersion. You know, I live in South Florida, so this is important to me. And I've seen quite a few drownings in my career. The biggest priority assessment is respiratory because their lungs were full of water and they were apneic. So remember, it's not that they're up and running around right after the occurrence. We could have their respiratory distress go and they end up dying because of their lungs 3 days later, up to 72 hours later. So we do hospitalize these children. GI system, remember, mouth to anus. I've always said it. Dehydration in children is extremely, extremely dangerous. There's no perfusion going to their major organs. Now, you need to know your ABGs, the metabolic acid-based things for your HESI. Very important. They will say, all right, you have a child vomiting. What metabolic acid-base balance are you going to see? Well, remember, if you vomit, you're vomiting out acid. So what is left? Alkaline. So you're in metabolic alkalosis. And then if you're having diarrhea, you're getting rid of those digestive juices, which are alkaline. So what are you left with? Acid, metabolic acidosis. So remember those things, you're going to be seeing them. Now, if a child is vomiting and you can't give them oral, you're going to be starting an IV. We can tell if a child is dehydrated by your electrolytes. So what do we do if a kid is vomiting, unable to drink? We're going to be doing a metabolic panel. We're going to be looking at those electrolytes, and we're going to start IV replacement. Remember, the bolus of fluid is never, ever with dextrose, never, ever with potassium. So plain normal saline or plain Ringer's lactate. Usually in the hospitals, they use normal saline, okay? Now, if the child then is able to take PO, you're going to start the infant's Pedialyte is great, or Gatorade or Powerade, and small sips, and they'll be taking it. So vomiting, as I said, if they're vomiting, you can give oral, give it. If not, you're going to be giving IV. And those exactly what I just said. So nursing care, if they're showing signs of dehydration. Now, what do you see with dehydration? Adult, child, don't matter. Elevated heart rate, decreased blood pressure, prolonged capillary refill, decreased urine output, right? All of these things you're going to see. And more than that. So if you start to see these signs, you're going to get that metabolic profile, which will diagnose that dehydration. You're going to start that plain fluid, normal saline bolus with no sodium, no potassium, and no dextrose. Now, when you get an infant in and the mother says, my baby's been vomiting for 2 days, my first question, and it should be yours, does it dribble out or does it go across the room? And if they say go across the room, immediately tell them nothing more to eat or drink. These children are hungry. They're not getting food. So if you give them more, they're just going to vomit. So we need to rest that stomach to get them ready for surgery. Now, when I hear they're vomiting and it's projectile, I'll take my hand right underneath the xiphoid process, and I want to feel that little marble, that little olive size, little hard mass, and you can feel it in children. It's quite impressive that you can. So we're going to start an IV fluid. We're going to make them NPO. And remember, because they're not eating, they need a slow, continuous infusion that has dextrose because they need the sugar. Now, diarrhea is a little bit different than vomiting. As I said, it causes metabolic acidosis. And as long as this kid's not vomiting, we can do oral rehydration. You don't need an IV unless the kid is not conscious and very lethargic and unable to. But most of the time, we just give them PO fluids, again, those electrolyte solutions, the Pedialyte, the Powerade, the Gatorade. And then, because if you don't give food, you're just going to have liquid stool. We need to start introducing a diet that's not full of salt or spice, and not full of spice, that will hurt their stomach. So there's many reasons why dehydration can occur. Again, the one way that we'll diagnose it with that metabolic profile, and we're going to give that IV. Appendicitis is something that happens to children, adults, all different ages. And as long as they have pain, that appendix is still intact inside. So what do? The child walks in. Children usually come in, if they're walking, you'll see them bent over and they'll be holding their right lower quadrant. And we make them NPO and we're going to start an IV. All of a sudden, and of course the ultrasound is going to diagnose it. And if all of a sudden their pain stops, we know that appendix has ruptured. So what happens when the contents from the smaller bowels and the large bowel spew into the peritoneum? Well, it's going to be peritonitis. That is a really, really horrible infection. So how do we treat these children post-operatively? Well, they can't eat or drink. We need to rest that entire bowel, mouth to anus, all needs to be rested because it is angry. It's got all of this stuff that is attacking the outside of the intestines, and it's painful and it continues. So we don't want anything inside to increase that. So we're going to put in an NG tube. Doesn't the stomach still secrete gastric acids? Yes, we don't want that. We want to rest the intestines. We're going to be given, of course, IV antibiotics. We're going to give IV fluids. It's a surgery. We're going to give them something for pain. And because it was ruptured and all of that toxic material was spewed in the peritoneal cavity, you must look at that dressing and that suture line because it was dirty and it could dehiss really easily on you. So this is one of those ones that checking the dressing is very important. You need to get them up out of bed. Make sure you medicate them before you try to do that. Cough, deep breathe, all of those things must be done. GERD, gastrointestinal reflux, gastroesophageal reflux. So you have your stomach and it just spews food up and down your esophagus. In infants, you're going to see them arch their back. It's very distinctive. Now, older children, you're going to see them coughing and they're going to complain of heart pain, heartburn, and they'll be holding like right in their chest. The reason is that food's going up and it's irritating them. Now, why are they coughing? They're having little mini aspirations into their lungs. So they're really getting aspiration pneumonia. So how do we treat this? Well, number one, we look at the diet and we're going to give them a medication. I mean, the slides still say ranitidine, Zantac, but we're giving Pepcid now. And that reduces that stomach acid and the diet. And there's all the medicines, PPIs, all of them can be given to children. And if that don't work, they're going to go for the surgical intervention. And the name of that surgical intervention is called a Nissen fundoplication. And they literally take the top of the stomach and fold it over so that you can't get the food going up and you're preventing that mini aspirations. Now, one of the things I didn't mention about reflux, because it's not this one, never mind. GI issues, sorry, I'm a little bit crazy today, as always. Hepatitis. Hepatitis is the liver inflamed because of whatever, it doesn't really matter what caused it. We need to treat it. Number one, you need to, protect yourself, wear your gloves, wash your hands. And how do we treat this? And it's usually diet. Now, there's always many choices of a diet. And you're like, well, they can't have that and they can't have that, and there's no answer that looks correct. Well, these children need the diet which is the lowest in fat, and that's how you choose it. You could get meat, fish, fruit, vegetables, and milk is a good choice. It's better than a milkshake or better than fried foods, okay? So remember, when you look for choices, look at the one that's less in fat. Celiac disease is when the small intestines does not like wheat, barley, oats, and rye. And it causes those intestines to spasm and cause severe pain. And how do we treat it? Well, we don't feed them those foods. We keep away from it. So, I mean, this is the one that if you have a child with celiac disease and you walk in the room and their lunch tray has soup with crackers, I'm immediately taking the crackers away, right? If they have something on that tray that has bread, I'm getting rid of it. Because sometimes the children say, well, I'm in a hospital, they know what they're doing, and they eat it. And then what happens? Then they hurt. And then I would feel horrible. Now, this is a picture of that bladder exstrophy. And all it is the bladder is up on top of the skin. Again, it didn't close like myelomeningocele, gastroschisis, bladder exstrophy. Those are the big three that you see where the insides are born on the outside. So this is the bladder. What are we going to watch? Well, intake output, right? And we've got to really keep that tissue moist, intact, and we have to prevent a lot of excoriation of the tissue around it. So we need to take good care of skin care here. And they usually do it pretty well after birth. They don't leave it open for a long time. But again, maintain that tissue integrity, prevent infection, sterile dressing, and moist, monitor intake output. Meckel's diverticulum. This is a little outpatching piece of tissue in the small intestine that rips and tears, and inside that is a blood vessel. They're usually pretty big. So what do you see? Well, it's small intestines, but you're going to see red blood coming out the rectum. It doesn't really hurt. So it's confusing. They think, oh, maybe it's just a hemorrhoid, right? Well, sometimes you see a little cramping, a little tenderness, but you will, if it allows to continue, you could go into a bowel obstruction. And how do we treat it? Well, we take out that diverticuli and they do well. Hirschsprung's disease. Think about the descending colon close to the anus that they forgot to put nerves in that area of the bowel. So it can't move, doesn't feel pain, and food just sits there. Causing is also called a megacolon. Because it's not moving, everything backs up and it can cause a bowel obstruction. It will get extremely distended. Usually, again, this is that newborn that does not have a stool within 2 days after birth. It's one of the things they'll look for. So how do we treat it? Well, number one, we do an X-ray and look what's happening. We'll do a rectal biopsy, and then we'll do a 2-part surgery. We'll do a colostomy, and then usually before the end of a year, they'll put most of the time, they can reverse it and put it down and have a regular bowel movement. Now, sometimes when the baby's born, you will have some stools, but what do they look like? You see that little tiny little straw-like tube? It's like taking icing and squirting it out into a cake, that little ribbon looking sort of stuff. that's what it looks like. It's not a big solid, it's not a liquid, it's ribbon shaped. Esophageal atresia, tracheal esophageal fistula. These are both things that causes a child the inability to have food go into the stomach without complications. Now, esophageal atresia, it's not connected to a stomach. Esophagus is there, stomach is there, there's no connection. Where does the food go? It comes back up and they aspirate it and choke. So how do we treat this? Well, number one, because you can't eat because it just comes back up and goes into the lungs. This child is NPO. You need to keep that airway open. So you need suction there. Now, you still have oral mucus, right? And they're still going to be swallowing a little bit, causing this aspiration pneumonia. So these children need antibiotics preoperatively because they are, and there's nothing we can do to stop it. So these children, NPO, IV fluids, and we are going to be given antibiotics to prevent infections from that, the swallowing of that liquids going into their lungs. Remember, this is a child who's not going to be able to eat. We must promote growth and development. This child needs a pacifier. Why? That's how they soothe themselves, right? The self-soother. I mean, my husband calls it a soother. Perfect name for a pacifier. Nephrotic syndrome. This has nothing to do with kidney failure. The kidneys are working. This is not kidney failure. This is a kidney saying, ooh, protein, I don't like you. Let me get rid of you. So the protein is taken out of the blood and you urinate all your protein out. So what do you see? Well, massive proteinuria. You're going to have 4+ urine protein when you do a dipstick. The protein that was in the blood is gone too. And you're going to have elevated lipids. And because it changes the levels of isotonic, hypotonic, hypertonic, fluid is going to be pushed out into the interstitial tissues. It's what the body does to try to make an isotonic solution. They like that 0.9 saline, that isotonic fluids. And without proteins, they'll spew it out. So what does this kid look like? This kid's going to be swollen. Again, this is urine. What is the treatment? Intake, output, daily weights, right? And because they're retaining, they're going to be on salt restriction and fluid restrictions. And these kids will get steroids to treat it. Acute Chlammalian nephritis. Well, acute Chlammalian nephritis is due to a recent, most likely strep throat that wasn't treated. So how do we treat it? Well, we treat the strep throat, right? So we give that to them. And we can turn around a lot of these symptoms here. So what do you see with acute Chlammalian nephritis? Well, oliguria. They're not urinating. You don't urinate, you're going to see edema. With all that edema, you see hypertension, hematuria, proteinuria, and that's usually when they get to oliguric, where they're not urinating. That's when the parents bring them in. Something don't look right. So again, it's urine. What are we going to do? We're going to do daily weights, intake, output, and we're going to be, because it's in the belly, the kidneys, we're going to do abdominal girths. The nutrition, again, low sodium, fluid restrictions. And these children are very susceptible to infections. So we really have to have good hand washing. Again, there's a lovely little picture that looks like it. Hypo or epispadias. I told my class I had a really good picture of what happens to that penis when the end of the urethra doesn't come where it should at the end of the penis. Hypospadias is underneath. Epispadias is on top, and anywhere on top. Doesn't have to be in a certain place, but it's not out the tip of the penis where it should. We usually do surgery before the potty training comes, so we try to do it, before the first year of life. And the one thing we need to tell our parents, especially those like in Jewish faith who want to do their bris, right? You cannot do a circumcision. They need that tissue to do a plastic closure, because you can see they fillet that penis open, and then they'll put a catheter of some sort in there to hold the integrity of that opening, the tube that goes from the bladder now up to the end of the penis, and they'll put a catheter in there. Now, it could be plastic, it could be all different types. The ones that I've seen is they use that catheter from a female straight calf with that little test tube, with that plastic rigid tube. That's the one. It's an 8 French, and they'll put it in there. Now, how do we take care of that catheter? Well, we just keep it inside the bladder. You don't touch it. Leave it alone. You don't want to do anything to damage, the opening that they have created. And then the urologist, urosurgeon will take it out about 10 to 14 days. And they actually do a really good job with it. Kidney disease, we know that you're either born with it or something's happened that you've damaged the kidneys. And one of the big concerns that we worry about is we know that they don't make the red blood cells the way they should. And we don't want to give more blood transfusions than we have to. So we're going to be giving this erythropoietin. And all it does, it makes more red blood cells. So we decrease the amount of transfusions required. Now, one of the other things with chronic kidney disease in children, and they're growing. So we want to make sure that the child has everything it needs to grow the way that they should. So osteodystrophy is something that's caused from vitamin D and calcium that they don't have enough. So we need to give those replacements. These children, we try to make them feel as normal as they can, but we know they're going to be on a machine how many times a week for how many hours. So it's a lot of time spent. One of the things they're doing a lot now, and even with adults as they start in kidney failure, they're putting them on peritoneal dialysis. It's done at home. It's done at night when the child sleeps. Parents are taught how to do a sterile procedure connecting this machine. It has looks like a scale on top, but it's a heating pad where you put the liquid called a diastolate, which is the liquid, whatever the nephrologist wants. And you purge the tubing, and it will instill into the abdomen. That catheter goes just into the abdomen. There's no specific place, just the abdomen, the cavity. And usually children get 150, 200 mLs. And they put it in there, and they let it sit there 20 minutes, 30 minutes, and then they drain it. And putting it in, sitting there, draining it is a cycle. They usually do 8 to 10 cycles a night. And then you take the Foley catheter where all of that urine is dripped into, and you subtract what you put in and how much is in there. And that's the urine output. The biggest concern on this procedure is infection. We must know that these parents have to know that if there's any change in that fluid color, or they're seeing stuff in there that they've never seen before, to immediately call their healthcare provider. This child is going to need an antibiotic. Remember, that's their kidney. You lose their peritoneum cavity, you don't have a kidney. Very important. Kidney biopsies. As I said, they're very similar to your cardiac type of catheterization. So they're NPO before, they are going to be coming back And how do we care for them? Well, these children have had a needle in the back inserted into the kidney. So we've punctured through the skin into the kidney to get some sort of biopsy or urine for whatever reason they need. When they're done, they put a really tight pressure dressing and a sandbag if they're old enough. They will be on bed rest 24 hours. We don't want that area to open and leak urine or blood into the peritoneal cavity. We will be monitoring it's a kidney intake and output for sure. And we're going to be monitoring that abdomen for tenderness, swelling, and also monitoring that dressing. So that is renal biopsy. Kidney transplant, the biggest concern is rejection. So we're, many things can cause it. These are the signs and symptoms. Remember, these children will be on immunosuppressants for life. And again, it's kidney. They're going to be getting the erythropoietin injections to try to help them also. Fractures. We have open and we have closed, compound, simple. Okay, what is that all about? Well, kids fall down with their hands out, and usually the radiator or the ulnar are the most common they get. Bikes, motor vehicles, sports, all those things are common causes of them. Now, if it's a normal closed type of fracture, you put a cast on it, and we're going to teach them how to take care of it. We're going to do, the rice, and then we're going to look at the 6 P's on this one. Now, if it's compound or open, what is the priority? What nursing priority for an open, like the top picture? You have a bone sticking out of the skin. Priority is antibiotics. Is it pain medicine? No, it's antibiotics. You don't want this child to go septic on you. So remember, priority antibiotics, okay? There's all types of fractures, and these are the names. I don't go into all of that. Neurovascular, these are the 5 P's. We'll be checking these things. We will also be teaching the parents and the child to look out. Pain is increasing, pulse that is going away. If it's getting pale, does it look pink? Can you feel it? Can you move it? These are all things you see. Cast care, keep it dry. Number 1, keep it dry. Have it elevated, move their fingers. If there's any swelling, pressure, any of the 5 P's, they need to get to the doctor. They might have to change it. Traction. Skeletal and skin are the 2 types of tractions that we talked about. The most cervical is just, when we put those devices around the neck or even tongs, but really it's skeletal. So what do we as nurses need to know about traction? Well, number 1, it's 24 hours a day. We don't take it off. We use it a lot in fractured femurs, and we approximate the bones because those big thigh muscles spasm and they'll pull those bones and they'll go in opposite directions, and little sharp edges will be extremely painful. So we immobilize it and keep it straight. What do we need to do? Well, you need to document the amount of weight that's on that on your nurse's notes at least once a shift. And also, those weights must be hanging free because it's not doing any pulling and keeping those bones apart. And we'll be doing neurovascular checks and checking those pulses, making sure blood flow is going along. So again, these are all the things that you will see. Checking the foot, making sure the ropes are hanging, the alignment, and they do, for older kids, give that trapeze so they can move around a little bit easier. Dysplasia of the hip, good old Pavlik harness. This is when the hip, instead of born inside the hip socket, it's born up. And we'll see it at birth. And the goal is to treat it as soon as possible because healing in infants, 2 to 3 weeks, they can heal a bone. So we want to get it in that Pavlik harness because we want it to be abducted, abducted, so that we can get that hip joint back in place. Remember, with DDH, you're going to see a shorter leg. You're going to see skin folds on the buttocks. One's going to be higher than the other. And you're going to hear positive Ortolani, positive Barlow. You're going to hear those clicking of those bones. That's why the pediatrician first does those clicking, looking and listening for it that first visit that you go in. Scoliosis, we could treat it 2 ways, right? We could put a brace on with exercise. But remember, this is usually that pre-adolescent growth spurt. And they're adolescents. What are adolescents all about? Body image, right? Their identities, body image, and they're in this brace. So it's quite upsetting for them. These children will be in that brace 23 hours a day. And just to take it off, to shower, change the t-shirt underneath and put it back on. Now, usually that's all they need. But if that curve is more than 45%, they'll be doing surgery. And it's called Harrington or Luque rods. And these are things that go on either side of the spinal column, and it attacks to it, tries to straighten it up. When we have a child post-op, Harrington rods for scoliosis, that back has to keep straight. They're flat in bed. You need to log roll those children. Very important. We don't want to dislodge that at all. And as I said, all about body image would be a great nursing diagnosis. Osteomyelitis is an infection of a bone. They could have stepped on something, they could have hit their hand on something. And usually when you think of entry from the skin into the body, you think staph. These kids, once we decide that it's an osteomyelitis, we need to treat them with IV antibiotics. They need a really good IV line, PIC line, Broviac, something to make sure they've got good access. Usually after like 6 or 8 weeks, they can put them on oral, but this is a long treatment and it could be 8 weeks, it could be longer depending on the child. And the one concern with infection in children is nutrition. They need fruits, vegetables, dairy, and protein. And you have to be careful with carbohydrates on these children, okay? And again, these children are going to be isolated. They usually stay home with this. So again, that psychosocial, make sure we got, FaceTime today, which is great. Kids can be with their other kids, right? Most of the time we can treat it and we don't need to do amputation, but it's mentioned. Lupus, body attacks all the organs, right? What are the signs and symptoms? Usually this starts about that pre-adolescent age with girls. Could be due to the hormones that go on. They really don't know. You're going to see that red rash, butterfly. You're going to be seeing their eyes are going to have that redness in them, and they're going to be needing treatment. And these children, let me see, you have the headaches and fever, and sometimes even seizures will bring them in for that. So how do we treat it? Well, we have to protect them from the sun. It's one of the big things that could cause flares, using sunscreen and limiting the amount. And these child will be getting prophylactic antibiotics before procedures. JIA is when we worry about the body is attacking the joints. I know all about it because, that's what I have to suffer through. But what do you see? What do you see with a kid? Well, this kid usually it's in the morning, it's stiff. hard to wake up. You're going to see them difficulty with ambulations, that stiffness, that joint disfiguration. And then this is the possible uveitis, where it can affect the eyes and it could cause vision loss. So something that does need to be looked at by a physician at least once a year. And then Guillain-Barré. This is where the nerves stop working, basically. And it starts in the feet and it ascends. So it's ascending. And when we are worried about it is when it attacks the phrenic nerve. And it attacks the phrenic nerve, it's going to stop the diaphragm from working. Well, what does a diaphragm do? It helps you breathe, right? So these children and adults will become unable to breathe. They're going to need to be intubated. You'll see them first with weak and falling, waddling. Then you're going to see problems with urinating, constipation, and then it goes up to the lungs. Remember, your priority care on Guillain-Barré is respiratory, because respiratory, they will not breathe. Now, symptoms will start, they'll go up to where they're going to end up usually at the lungs and the phrenic nerve, and then they're going to sit there for a while. Treatment is the IVIG, the intravenous immunoglobulins. And then all of a sudden, they're going to start breathing, and then the weakness dissipates, going from descending from phrenic nerve down to the feet. So you're going to have the same basic dosage calculations you've been seeing. I have put the last three cahoots here on this review so that you can go back and you can look at them. I highly suggest it because there's all the concepts that you're going to need to know. So I know you can do it. You're going to ace the exam. So I wish you good luck. Any questions? Is your head dizzy now? All right.
Thank you so much.
My pleasure. Anybody who wants to stay over and talk more about things, we can.
Professor